thanks, Sam. A housekeeping reminder to enter any questions in the Zoom webinar Q&A function or in the chat. A link to this recording will be circulated to all registrants and made publicly available within the next day or so. The chat function has been enabled for audience interaction. So just for warm up, those of you who are willing, please say hi in the chat, your affiliation, if desired, and from where you are logged in. So many thanks to those of you who have submitted excellent questions. The panelists will try to get to as many as there is time for. Turning the mic now over to Alexander Zan Fleming, MD, founder and executive chairman of Kinexum, a regulatory, clinical, and product development strategic advisory firm, and founder and president of the not-for-profit Kitalis Institute, whose mission is to catalyze science into solutions for preventing chronic disease and extending healthy longevity for all. Zan?
Well, thank you, Thomas. I hope you can hear me. It's getting windy outside. I'm here for a purpose, and if I stop to fall apart, let me know and we'll make other arrangements. But we do welcome our friends and experts and collaborators from around the world. I'm thrilled that we're bringing together people from the two worlds in which I live, the worlds of diabetes and neuroscience. I'm standing in front of the Potomac River, 62 miles up the river from the Capitol in Washington. And this backdrop is intended to support a kind of meditation on the key question for us today. How would we know if an intervention, and let me flip these slides if I can. How would we know if the intervention, whether a pill, an injection, a medical device, or a dietary supplement, could slow the aging process and onset of multiple chronic diseases and even cancer? How could we get to a product with a label like the one in front of you, as it may be? My neuroscience world has shown high likelihood that we can bend the aging process and slow the onset of multiple chronic diseases, cancer, and disabilities that are age-related. My diabetes world provides not only a human model of accelerated aging, but the tools for identifying and managing risk of cardiometabolic diseases. Measures such as LDL cholesterol and hemoglobin A1C are exactly what we need to answer the question about whether a product increases health span, and to do it within a few years, not a few decades. To address that how would we know question, we have a landmark session today, and it's open for your participation. We'll be getting to your questions throughout the discussion. Now, as an endocrinologist at FDA, I was involved in approving the first drugs on the basis of the surrogate measures, LDL cholesterol and A1C. Those approvals included the statins, oral and injected diabetes products, and the unique drug metformin. Later, I became interested in not just preventing diabetes, but in preventing multiple chronic diseases, with the conviction that not only can we do it, but we must do it for multiple reasons. This led to our first conference in London in 2017. And after 200 sessions later, today's session. The diabetes world and the neuroscience worlds do not intermingle as much as they should, but our panelists today have been changing that. Jay, Jerry, and Ralph are legendary in the diabetes world, but they are crossing over into the neuroscience world. All have participated in our conferences multiple times. But more recently, they've crossed over to healthy longevity audiences, like the Peter Attia podcast, for example. Ralph and Jerry are preeminent in studying the mechanistic roots of cardiometabolic diseases, and Jay is equally accomplished as a prolific clinical trialist in the type 1 and type 2 diabetes worlds. Today, we're going to focus on insulin resistance as not just a mechanistic root cause, but as the potential basis for a biomarker or surrogate endpoint that could accelerate the development of healthspan products, just as did LDL cholesterol and A1C for cardiometabolic products, including the explosive field. I hasten to add, though, that insulin resistant one of multiple approaches for clinically identifying and managing aging risk, and perhaps approving healthspan products. We'll come back to other approaches in future sessions, but we start with insulin resistance because it is further along. In fact, if you are a healthcare provider, you can now order an insulin resistance test right now. It's early days for insulin resistance, but I have seen early days before and what can happen from there. So Alf, you've been in the thick of developing every diabetic therapeutic class, but you always start with mechanisms, and that's a good place to start. Over to you.
Okay, I'm going to see if I can get my slides up to start the program. You can stand up. Hold on. Give us just a second to get the slide deck up, and we'll get underway. Okay, I think everybody can see this, I hope. So again, we're here to talk about insulin resistance, and I believe, and I think for sure Jerry and I will sort of sing a similar tune, believe that insulin resistance is a foundational defect. Of course, it's easy to demonstrate it in people with type 2 diabetes, but we've also shown it in people with pre-diabetes, and the new term that I've called pre-diabetes. And I think the link between diabetes and aging and geroscience, I think, is pretty tight. People with type 2 diabetes and also for type 1 diabetes, their lifespan is reduced, and they have multi-organ system disease, affects the central nervous system, affects the heart. So if we can get insights in how we may prolong things in life and hopefully correct the underlying insulin resistance, maybe this will lead to an extension of life. So this is an old study, and it was one of the first studies that we carried out, which I think really highlighted the importance of insulin resistance in this sort of glucose intolerance diabetes cascade. So in this study, which was carried out in San Antonio, it's very easy to find Hispanic parents where both the mom and the dad have type 2 diabetes. And what we did is we looked at the offspring of the parents. But we had some characteristics that made it a little bit difficult to find the appropriate offspring because they had to be lean and they had to have normal glucose tolerance. And we used the euglycemic insulin clamp, which I developed many, many years ago. And this is really the gold standard for measuring insulin sensitivity. And we infused insulin at 2 different infusion rates. The basal rate of glucose disposal is the first 2 bars in the offspring, orange, and the controls, yellow. And then a lower dose at 20 milliunit per meter squared per minute, and a higher dose. And you can see that in the offspring, at both doses of insulin, there's quite severe insulin resistance. And with the insulin clamp, all of this glucose is being taken up and disposed of in muscle. We used tritiated glucose so that we could quantitate hepatic insulin sensitivity. And we didn't really see a defect at the level of the liver. All of this insulin resistance was at the level of the muscle. all of these people had a normal oral glucose tolerance test. And we wanted to look at their insulin response. So we used the hyperglycemic clamp. And to the left is the plasma insulin response. To the right is the plasma C-peptide response. This may have some relevance to the Lilly study, to the insulin resistance test that Zan just mentioned. And with the hyperglycemic clamp, we raised the plasma glucose concentration by 100 milligram per deciliter. And you can see that clearly the offspring are hyperinsulinemic. So they're able to read the severity of the insulin resistance and respond appropriately. And I think these studies showed very clearly that long before you develop diabetes or prediabetes, that the insulin resistance is really quite well established and really quite severe. But as I said, this was an Hispanic population, so we wanted to broaden this and look at other populations. And these are data from two studies, the San Antonio Metabolism Study and the Veterans Administration Genetic Epidemiologic Study. And we, again, performed insulin clamps. There are a very large number of people in these studies. And on the bottom, we divided these normal glucose tolerant people into three groups based on their fasting glucose. And you can see that even within the range of what would be considered to be normal glucose tolerance, that there is quite significant insulin resistance. And then if we look at the people who have a fasting glucose 100 to 126, the impaired fasting glucose, you can see that the insulin resistance progresses. And by the time you develop overt diabetes, these people are already severely insulin resistant. Maybe it gets a little bit worse as the diabetes progresses, the 4 red bars. But I think what you can see is that you can almost draw a straight line from the people with the fasting glucose less than 90 up to those with the fasting glucose 140. So the insulin resistance is established very early. Now, over the years, we've had the opportunity to do euglycemic insulin clamps in a large number of people who you would probably characterize as having the metabolic syndrome. I prefer to call it the insulin resistance syndrome. The control group is shown at the left, and the height of the bar shows you the rates of glucose uptake during the insulin clamp. So if you look at lean type 2 diabetics, green, obese normal glucose tolerant individuals, people who had essential hypertension, people with hypertriglyceridemia, the last bar, the people with impaired glucose tolerance, they all very severely insulin resistant. And the purple bar was a study that Peter Bressler performed, where we looked at people with established coronary disease, determined the term cardiac cath, and compared them to people with normal coronary arteries. And you can see these people were also very severely insulin resistant. So insulin resistance is a hallmark feature not only of diabetes, but a lot of other disorders, including obesity, cardiovascular disease, and hypertension, all of which shorten the lifespan. So at the molecular level, and these are all human data carried out with Larry Mandarino when he was with us in San Antonio, looking at how insulin works. And I'm going to make a point that I think clearly establishes the tie between diabetes, cardiovascular disease, and shortened lifespan. So in order for insulin to work, it needs to bind to the insulin receptor. There's a insulin signaling pathway in which IRS1 gets tyrosine phosphorylated. You activate PI3 kinase, AKT. Glucose enters into the cell. But what's less well appreciated is that you also activate nitric oxide synthase, and you increase nitric oxide, which is one of the most powerful vasodilatory agents in the body. It's also a powerful anti-atherogenic molecule. So what goes wrong in people with type 2 diabetes? Well, there's a normal ability of insulin to tyrosine phosphorylate the insulin receptor, but an inability to activate the insulin signaling pathway. So what happens? Glucose doesn't get into the cell. That's diabetes. You don't generate nitric oxide, and that's cardiovascular disease. So it's virtually impossible to dissociate insulin resistance and cardiovascular disease. They go literally hand in hand. And so we then came back to the offspring. So these people, as I showed you before, they're quite severely insulin resistant. They have perfectly normal glucose tolerance. And the ability of insulin during the insulin clamp to tyrosine phosphorylate the insulin receptor actually is increased, and that's because they're hyperinsulinemic. But you can see the ability to activate IRS1 and the PI3 kinase AKT system is markedly impaired. So these youngsters basically have the same defect as their overtly diabetic parents. So this insulin resistance starts very, very early, and that means that all of the sort of bad things that go with insulin resistance, atherogenesis and particularly, have already started at a very early age. So this in a certain way is a phenotype, insulin resistance, but we were interested in terms of what at the cellular level might be responsible for this insulin resistance. And so we did muscle biopsies and we measured ATP synthesis. And you can see in the obese and the type 2 diabetics that there's a marked decrease in ATP synthesis. And more recently, we actually developed an in vivo technique using MRI technology and showed similarly that in obese type 2s, and not shown in this slide, people with prediabetes also have a severe defect in the ability to generate ATP. And if you look, you can see that this defect in ATP synthesis is strongly related to insulin resistance. So we are very, very much sort of along the line here that insulin resistance, in fact, may be generated by a defect at the mitochondria. And I think this will be a good introduction now to turn things over to Jerry, who really has done an enormous amount of work in this area. So I'm going to get rid of I'm going to stop sharing my slides. And I think I've done that. I don't know whether Zan is going to make a few comments about Jerry or Jerry's going to come on directly.
Zan, do you want to say anything? Okay, well then I'll start. So thank you, Ralph. So go ahead, Zan.
Sorry, Jerry, I apologize. I was having a technical issue. I think we will come back to Ralph and our other panelists for questions in a moment. But terrific, Ralph. Thank you for a great start. And we continue with another expert in the field, Jerry, who is at Yale and a real powerhouse in the basic research around cardiometabolic risk and the basis for it. So Jerry, take it away.
All right, thank you, Zan. Great to be here, and Ralph, that was magnificent as always introduction, and a really pleasure to be here and share with you some of our work on this topic. And so, you know, again, this is one of my favorite slides. This goes back to our dear colleague Jerry Reaven, who in his Banting lecture in 1988 first called, I think, everyone's attention to this clustering of things that with insulin resistance, you know, both, of course, heart disease. This is what leads to the demise of our patients, high triglycerides, low HDL, hypertension, polycystic ovarian disease, high uric acid. And I think it's fair to say at that time, again, these were association. A lot of people might have been skeptical, saying these are common things. Maybe they're clustering together. And now, as we move to current times, we can now add fatty liver to this constellation, MASLD, MASH. Metabolic syndrome is now the most common cause of MASLD and MASH and end-stage liver disease, and the requirement for our patients to undergo liver transplantation. Obesity-associated cancers are skyrocketing, and I'm sure they're related to the hyperinsulinemia secondary to the insulin resistance. Insulin's a growth factor, and certainly through IGF could be promoting, and there's very strong preclinical data from my colleagues, Rachel Perry, who's shown in preclinical models, insulin resistance is driving breast cancer, colon cancer, and if you fix insulin resistance, you slow down tumor growth. And even Alzheimer's very strong data correlating both not only diabetes, but insulin resistance to Alzheimer's. So this is really potentially the thing that is probably, to me, one of the greatest threats to humanity in the 21st century. And I'm going to both in this next several minutes basically give you a molecular basis, at least how I think what causes insulin resistance, because you need to understand a molecular basis if we're going to come up with new therapies to treat it, and also share with you causal evidence to show you insulin resistance actually is driving fatty liver disease and MASH and atherosclerosis. So again, evidence that, again, if we can come up with drugs and fix insulin resistance, we can do a lot of good for our patients. So again, because of time, I'm going to just give you a high-level overview of what the molecular basis for insulin resistance is. And one of the bottom lines and the key conceptual points I want to make, it's about ectopic lipid, fat in the wrong places. And so we developed NMR methods to actually measure fat, not only in the muscle, but what's inside the muscle cell. That's the intramyocellular lipid content. That's, again, with proton NMR, we can actually see the fat inside the muscle cell. And using the clamp method that Ralph introduced to you, this is how much glucose we're infusing during a hyperinsulinemic euglycemic clamp. This is the best predictor of insulin resistance in adults. The more fat you have inside the cell, the more insulin resistant you are. We've done this in young people, we've done this in the elderly, we've done this in children. In sedentary individuals, it's the fat in the muscle. This is probably the best marker for insulin resistance, at least in our hands. I'm going to fast forward about 30 years worth of work, then trying to understand the molecular basis for how fat inside the cell causes insulin resistance. And again, this gets into the weeds a little bit. It's a little bit of basic biochemistry here, but Zan wanted me to discuss basic mechanisms, because if we understand basic mechanisms, we can then understand really new ways and approaches to treat it. And so to summarize, again, the last 3 decades, we've identified through lipidomics, this is the bad actor, diacylglycerol. It's the penultimate step in triglyceride synthesis. We've gone on to show triglycerides are just a neutral marker. So you measure fat. I showed you the IMCL correlates with insulin resistance, but this is really more of a marker for the bad actor, diacylglycerol. Diacylglycerols are known activators for NPKCs, and the two in muscle are epsilon and theta, and we've shown, inhibit the insulin receptor kinase pathway. And Ralph gave a nice introduction for you. And so we've shown epsilon directly binds to the receptor, phosphorylates it, and inhibits receptor kinase. And then this other novel isoform hits the insulin receptor substrate 1, phosphorylates this, and then prevents its binding to PI3 kinase. This is a required step for insulin-induced GLUT4 translocation to move glucose inside the cell. The key concept I want to leave you with is this imbalance between fatty acid delivery to a cell relative to rates of oxidation by the mitochondria, and we just heard about mitochondria from Ralph, versus storage as neutral lipid, triglyceride. So when you have an imbalance of the fluxes, this accumulates, and it only takes a spike in diacylglycerols to activate this novel PKC pathway to inhibit receptor kinase activation and the receptor insulin receptor cascade. And again, we've been able to prove this using the power of transgenic mice and knockout mouse, and basically showed when we target LPL to the muscle cells, more fatty acid delivered to the muscle cells, DAGs build up, muscle insulin resistance. When we block fat oxidation in the knockout enzymes that block mitochondrial fat oxidation, DAGs build up, you get activation in this pathway. And conversely, for therapy, we've shown when you promote mitochondrial inefficiency by overexpressing an uncoupling protein 3 in muscle, we get reduction in DAGs, less NPKC activation, and protection from lipid-induced muscle insulin resistance. This is muscle. And we've gone on to show the same thing happens in the liver cell. So here's a cartoon of the liver cell. And we've gone on to actually drill down even more basic, where fatty acids are fluxing to the cell. And the fatty acids go up the smooth ER and synthesis into the SN12 DAGs. There's different isoforms of diacylglycerols. It's a stereoisomer, and it's only the SN12 that will activate the novel PKCs. So unless you're measuring these specifically, you're going to miss this. And more importantly, we've shown that it's in the plasma membrane. It's these SN12 DAGs that accumulate in the plasma membrane. Those are the ones that lead to the NPKC translocation. And for epsilon, we've gone on to show it phosphorylates a critical threonine in the insulin receptor catalytic domain, which then blocks the tyrosine autophosphorylation and blocks downstream insulin signaling. Very important concept. So you read the literature. If you think about insulin resistance, sometimes more often than not, lipid inside liver and muscle cells correlate with insulin resistance. But then you always hear someone saying, "Well, look, I have a mouse or even a patient, a lot of fat in liver, no insulin resistance." And we've shown then it's all about compartmentation of these bad-acting lipids, the SN12 DAGs. When they're in a lipid droplet, there is no insulin resistance. So it's almost like putting fat in the subcutaneous fat. That's a very good place to put fat. And when the DAGs and TAGs build up in lipid droplets, no insulin resistance. And this explains many models of huge fatty liver, not only in animal models, but in humans with ATGL or CGI defects, or they can't export the fat, MTTP knockout, huge fat in liver, no insulin resistance. And if you biopsy and just measure DAGs, they may be increased. And we've shown it's because it's in the lipid droplet, not in the plasma membrane, no NPKC translocation, no insulin resistance. And those of you who study the athlete's paradox, and again, that was always a question, athletes actually are super insulin sensitive. They have more fat in the muscle, but we've shown actually both in animals and humans that are well-trained, they do have more fat, more DAGs, but it's all in the lipid droplet, not in the plasma membrane, and that explains the lack of insulin resistance. One other point for those of you who, again, drilling down into the weeds, not only does the NPKC, especially epsilon, hit the receptor, dozens of other downstream steps, including S6 kinase. And so some of my colleagues say, yes, there's many downstream defects, not only at the receptor, but further downstream. And these other downstream defects in such as S6 kinase can explain these other downstream defects. So we've now gone on to show the same mechanism of DAG activation of the NPKCs is not only in liver, not only in muscle, but also in fat and also in the kidney. The kidney is insulin responsive, actually, and the renal cortex. And you actually get lipid-induced insulin resistance in the kidney. So all these organs are impacted through this mechanism. And you almost have to scratch your head. So, and again, we actually look at this pathway, the PKC epsilon pathway and phosphorylation is conserved from humans all the way down to fruit flies. And that's hundreds of millions of years of evolution. And, here I gave the introduction, both Ralph and I talk about how bad insulin resistance is. And here, this pathway that causes insulin resistance has been conserved, again, through hundreds of millions of years of evolution. One has to ask the question, why has nature conserved this, what's now a very detrimental pathway? And the answer, which I will propose to you, is this. And so we've shown that with starvation, you get increased lipolysis, more fatty acid delivery to these organs, and triggering of this insulin resistance pathway. And during starvation and then refeeding, this is important for survival. It basically prevents you from storing glucose as glycogen in liver and muscle and keeps it available for CNS, red blood cells, and the renal medulla. So that, to me, is the evolutionary basis for lipid-induced insulin resistance. And now in our toxic environment of overnutrition, we're triggering this pathway and leading to this pandemic of insulin resistance and cardiometabolic disease. So that was my basic science approach. Again, ectopic lipid, specifically lipid in the wrong places inside the cell, and particularly the diacylglycerols activating the insulin resistance pathway. I now want to just show you, building on what Ralph talked about, of young, healthy individuals who are insulin resistant, because I think this is really, I think what I'd like to focus. I'm going to go both start with the young and then just move to the the elderly, because this topic we're talking about gerosciences here. So this is the demographics of mostly healthy, lean, young Yale undergraduates, 18 to 21 years of age. You give them a drink of glucose. You measure insulin sensitivity using the Matsuda index that Ralph developed, measuring insulin levels. And to me, the real surprise, these are all sedentary individuals, is the broad distribution of sensitivity. Look at this, all the way from 2 to 10, really bell-shaped, almost a bell-shaped distribution. And so by definition, these bottom quartile are resistant by the ISI, and these folks are sensitive. And we asked a very simple question, is when you take in carbohydrate, do you store energy differently if you're in the bottom quartile versus the top quartile? So we gave these resistant in yellow and the sensitive in blue 2 high carbohydrate meals and measured glucose, and not surprisingly, not different. And again, Ralph talked about his experience in the pre-diabetic individuals. And the reason, excuse me, they're normal glycemic. So the beta cells are working overtime, pumping out twice the amount of insulin. And remember, the liver cells seeing 3 times this concentration. Liver cells are seeing almost 500 to 600 microunits per mil of insulin. We can measure where this ingested carbohydrate is going with both carbon NMR to measure glycogen changes and proton NMR to measure fat changes inside liver and muscle cells. And I didn't have time to get into this, but this is what we've shown previously, is when you're insulin resistant, most of that insulin resistance is a defect getting glucose into muscle glycogen. And these young individuals have this same problem. They can't get glucose stored properly as muscle glycogen, and this is due to a defect in transport activity, but no problem getting glucose or carbohydrate ingested into liver glycogen. So just consistent with what Ralph showed you, is a problem getting glucose into the muscle. And where's that glucose going? It's going to liver fat. So this is proton NMR measurements, changes liver fat. It's increased 2-fold. Oops. And we can actually quantify how much of that fat is coming from de novo lipogenesis. That's the conversion of glucose to fat using heavy water, which was in the milkshake, tracking it into the backbone of VLDL. And that's increased by 2-fold. This explains then the increase in liver fat. And when the liver is geared up to make more fat by DNL, it exports more fat. So plasma triglycerides are already increased 80% in the resistant individuals, and that leads to reductions in HDL. So conceptually, the key point I want to leave you with is this is where you want to be. This is when you're sensitive. This is the top quartile. This is common, 1 in 4 individuals. When you ingest your carbohydrate, you want to store it as glycogen. If you're that 1 in 4 individual who's insulin resistant, and if you're already overweight or obese, you're probably already here. You have increased IMCL blocking transport activity. The ingested glucose cannot be taken up and stored as glycogen. It's diverted to liver. You have portal vein hyperinsulinemia. You're revving up SREBP1C, the master regulator of DNL, de novo lipogenesis. That converts that carbohydrate to triglyceride, high triglycerides, low HDL. This is your atherogenic dyslipidemia, leading to your first heart attack in your 50s if you're not careful. And with time, this is what's driving fatty liver disease, which we talked about now, the most common cause of cirrhosis. To test this hypothesis, we went on to see, can we reverse this? And studies we did, again, many years ago, we were able to take these resistant offspring and showed with exercise training, we could actually normalize insulin-stimulated muscle glycogen synthesis. We can get into the molecular mechanisms of how this works. One of the questions related to this, AMPK activation, and AMPK will bypass that defect I showed you in insulin activation of PI3 kinase. It kind of short circuits it, so it causes GLUT4 translocation independent of that defect in lipid-induced blocking of insulin signaling. So knowing this, we actually said, will exercise reverse this defect? So to test this hypothesis, we took these insulin-resistant individuals, we exercised them, and we showed that you could normalize then glucose disposal into glycogen, lowering DNL, lowering liver triglyceride. So the key concept here is if we can fix insulin resistance, first of all, it happens first in muscle. And if we can fix this defect in muscle, we can fix the atherogenic dyslipidemia and an eventual development of fatty liver disease. And so not only the message here is we should all stay active, whether or not I think we're sensitive or resistant, but if we could come up with agents to fix insulin resistance, this, to me, we should be treating insulin resistance in young, healthy people like we treat cholesterol, hypercholesterolemia, and hypertension, if we can do it safely and inexpensively. Fix insulin resistance, and we can prevent these things from happening. And is the evidence taking this to humans? Again, fatty liver, and this is, again, one of my favorite studies. This is, again, I think how the GLP-1 incretins are working. I'm sure we'll have questions about that. This is, again, we did this 20 years ago before fatty liver was popular. We studied, this is what I would see in my clinic, type 2s in the mid-50s, fasting hyperglycemia. We and others, and again, studies by Ralph and Jerry Olefsky, this was, again, related to the reason patients have fasting hyperglycemia is this increased rates of glucose production. We were able to go on and show this is due to increased gluconeogenesis. And again, this is and this is also hepatic insulin resistance in these individuals. And here, with just a 1,200 calorie 88 diet, after 6 to 8 weeks, we're able to normalize fasting glucose. This was due to reduction in hepatic glucose production, and we showed that this is reduced to reduce gluconeogenesis. And again, we'll talk about metformin. This is what metformin does. And we're able to normalize insulin's ability to suppress glucose production. So what's accounting for this? The first key point here, again, this is only required 10% weight loss. This was, again, 20 years ago, and now everyone talks about that's all it takes is 10% weight loss. And again, this is why the incretins are doing so well. Again, they get 20% loss, but again, it's with this threshold. This is the second point. This is well established now, but again, this is 20 years ago. Every poorly controlled diabetic we put in the magnet has fatty liver 10 times normal. This was news at that time. Now it's well established. And the third point is just this modest weight reduction gets rid of this relatively small pool of fat, and that makes a huge difference. Getting rid of that fat in liver fixes the diabetes. Key point, they still have muscle insulin resistance, but they're not diabetic anymore. So I think, again, the liver fat pool is a great target to fix type 2 diabetes. A key conceptual point here is what's normal in terms of liver fat. Most of my hepatology colleagues always talk about the 5.5% threshold. It's actually much, much lower than that. So this is a study in 1,500 mostly young individuals that we study. The threshold is actually 2%, and it makes a difference. This is a threshold phenomena. We all get excited again in the fatty liver world, 20, 30% reduction by drug X or drug Y. it's there to me, it's not a relative percent reduction. That's nice, but I think we really need to think about an absolute threshold of less than 2%, because here in this paper that Kit and I published a few years ago, we showed that even if you're above this threshold of 2% liver fat, actually 1.85%, you still have insulin resistance, you still have hypertriglyceridemia, increased LDLs, high uric acid, increased diastolic blood pressure, and low HDL. So this is a very important point. Maybe we'll get into this, that we need new drugs to not only just relative reductions, but actually there's going to be a threshold that we really need to achieve. And then finally, just to end up on, because we're talking about geroscience and aging, I'm going to show you the same concepts apply to all of us as we age. So this is the NHANES study, and here we are, age 65, and 40% of us have either IGT or diabetes. It's really a profound number. And again, we all know as we get older, we put on weight, we become less active. These are all things that will contribute to insulin resistance and diabetes. And this was we wanted to see, are there other factors that contribute to insulin resistance, even if you're over 70 or 65, but you're lean. So these are lean 70-year-olds that we studied, Kit and I studied, BMI 25, matched for fat mass, body fat, lean body mass, normal glycemic. And we have a very simple question, are they, these healthy lean 70-year-olds different? And I won't show you the GTT data, but the glucoses are relatively normal, but they're hyperinsulinemic. And this is why, again, they have profound muscle insulin resistance. Again, lean, healthy 70-year-olds. And we can measure, I showed you liver fat and muscle fat, and they're both up. Healthy, lean 70-year-olds, increase IMCL and increase liver fat. And the question is, why is fat accumulating in lean individuals? Is it a defect in the fat cell delivering more fatty acid? Or we heard about the mitochondria. Is it a problem there? This is where we burn the fat. So we did microdialysis experiments and really no differences in basal or insulin suppression of lipolysis, and turned our attention to the mitochondria. And we developed the first in vivo studies to measure mitochondrial activity. And we did this in two independent methods. One was carbon NMR. We developed a method to measure oxidation in vivo. A lot of people do things with muscle biopsies, but I always worry about the environment of what you're measuring in that biopsy when you put it into the seahorse machine. And so this is in situ carbon measurements of oxidation, and it's reduced in the elderly. And an independent method, phosphorus NMR, we developed method to measure ATP synthesis, and that's also down by 35%. So conceptually, what's happening is as we age, our mitochondria are slowing down 35%, not clinically significant in that you can still walk and do fine and do activity, but it's a predisposing factor, this 30% reduction. If we don't change energy intake, this is predisposing us to ectopic fat buildup as we age, DAGs, more importantly, and insulin resistance. We've gone on to show this is happening, unfortunately, in all of our tissues. This is a study we did with our colleague, Doug Rothman. We can do the same measurements of mitochondrial activity in the brain, and our neuronal rates of mitochondrial oxidation are also slowing down in 70-year-olds compared to 20-year-olds by about 28%. Can this be fixed? This is an interesting, provocative study I want to share with you. We've all known about ROS, damage to mitochondrial DNA. Mitochondrial DNA do not have the repair mechanisms that nuclear DNA, and it's been a hypothesis that's been discussed for many, many years. And studies by Peter Rabinovich has shown that when you overexpress MCAT to the mitochondria, you can actually reduce mitochondrial DNA damage. And so studying these mice, we asked the question, well, can these mice, this is mitochondrial catalase targeted to the, let's say catalase targeted to the mitochondria. And so we studied these mice and we showed that just like humans, with aging, the mitochondria slow down with aging, and that when you overexpress catalase in the mitochondria, they are protected from this reduction in mitochondrial activity as they age. And again, this is this age-associated reduction in insulin sensitivity in old mice by clamp. And when you overexpress and protect the mitochondria, you protect the muscle insulin resistance. So I think, to me, this is the strongest evidence that aging is associated with reductions in mitochondrial activity. If we can preserve mitochondrial activity as we age, we can prevent ectopic lipid buildup and muscle insulin resistance, and probably liver insulin resistance. So these are my last slides here. There are multiple ways to get this ectopic lipid buildup, not just one way. And again, ectopic lipid inside the cell is what drives insulin resistance. All of us can get there independent of our genetic background, simply overnutrition. We spill over from the ability to store fat in the fat cell. And I'm going here. And we get spillover, and there's a threshold. We didn't talk about this. We will maybe in questions and answers. There's a genetic predisposition, especially on our Asian Indians. They get spillover to ectopic lipid even when they're lean. And then this, we've shown they are prone, even the BMI, they have more ectopic lipid in liver and fat. Certainly, when you have no fat, we've shown with lipodystrophy, you get buildup of, can't store the fat in the subcutaneous fat, and it builds up. And again, there's partial lipodystrophy with HIV and HIV medications. And I think this is what's happening in our different ethnic subgroups, the inability to store fat properly in the subcutaneous fat, and it spills over. And conversely, we've shown this is how the TZDs are working, is they reduce, they promote fat storage in the adipocytes and secondary lower it in liver and muscle. And this is why they are insulin sensitized in aging. I'm sure Ralph will have more to say about TZDs and pioglitazone. And we've also shown, our group has shown that adiponectin actually works in this way by stimulating lipoprotein lipase in fat and lowering fat in liver and muscle. And then finally, the mitochondria, which we just talked about. We've shown with healthy aging, mitochondrial slow down. We've shown that in the offspring of parents with diabetes, as Ralph showed you, we've shown independently that mitochondria, both with ATP synthesis and oxidation, slow down, predisposed to ectopic fat buildup. And now, as people are looking carefully, there will be genetic variants that will be identified that will predispose to ectopic fat buildup and insulin resistance. And my prediction is there'll be variants that actually have increased rates of oxidation. They'll be more subtle, but these individuals, if you're lucky enough to have that, you will be protected from ectopic fat buildup and insulin resistance. But then this leads me, and finally, to me a very nice therapeutic target. If we can promote mitochondrial inefficiency, we might be able to protect against ectopic lipid, insulin resistance, and all these other bad things associated with it. And so this is now a concept we've been tracking for the last 10 years. We're now, I should say, in human studies, phase 2 studies showing safety and efficacy. But the concept is we know about how well the incretins are working through decreased energy intake, and we'll talk about that. But here we're promoting increased energy inefficiency through protonophores. And by doing that, we lower ectopic lipid, and we lower not only DAGs, tags, but more importantly, DAGs, less NPKC translocation. We've shown when you burn the fat in the liver, you have less inflammation, you can reverse fibrosis, and you lower acetyl-CoA, you less gluconeogenesis. And most importantly, when you burn the fat in the liver, you export less fat, and it's heart healthy. So you have lower triglycerides, lower LDL. And this has now been shown both in animals, but non-human primates, and most importantly in humans now, independently by multiple different protonophores. And you export less fat to muscle. And this is now, then you will have secondary improvement in muscle sensitivity by lowering ectopic fat in skeletal muscle. So I think, and this is against this aging. This was an aging mouse study. We've showed this approach actually works in aging mice. This was done by our colleague at the NIH, Rafa DiCalbo, who did the mouse studies. And he showed that with aging, this approach, promote mitochondrial inefficiency, less hepatic steatosis, less inflammation, less oxidative stress, and increase the sensitivity. And in female mice don't die of heart disease; they die of cancer. And at least the female mice are protected from hepatocellular carcinoma by reversing insulin resistance through this approach. So that is the end of my talk, and I look forward to questions. And if I can just turn off my screen here, stop share, we're back to questions.
Wow, Jerry, bravo. Amazing tour de force presentation, elegant and profoundly important, and a great progression from Ralph's excellent start. And now we are on to Jay Schuyler for what will be a more clinical perspective. So thank you,
Yeah,
Jerry, and take it away, Jay.
Ralph, you wanted
I
to
did.
say something?
yeah. Whatever happened when we transitioned from Jerry, I can hear you all, but they cut off my screen. So I don't know what they did, but as I said, I can hear you, but I can't see anything on my screen. Maybe you can fix it internally. But go ahead, Jay.
Saif, can you look into that while Jay is going through his talk, please?
We do see you, Ralph, even if you can't see us. So
Oh, okay,
hang
good.
tight.
Hello. I'm waving to you.
You're good. You're with us. And now
Okay,
we're
good.
on to Jay. So take it away, Jay.
Well, thank you. So the subject really is the health span in 2025, and looking at it, if I can get the slides to advance, what we've seen is that lifespan, life expectancy at birth in the United States versus other countries has really remained much lower and has even dropped lately. We've bounced back from that. Some of that dip may have been COVID in there for a little bit, but the reasons for that may very well be the cumulative change in the share of U.S. adults with obesity has risen by 125% since 1990. Diabetes has risen by 75% since 1990. Hypertension is reasonably well controlled and hasn't been rising very much. You know, one of the things that I always go back to when we talk about blood pressure is the National High Blood Pressure Education Program, which was instituted in 1972. We went out to churches, to all places all over the country, and advocated for getting blood pressure below 140 over 90. And that was different than the rest of the world at that time. The rest of the world used the WHO definition for blood pressure, which was 165 over 100 that they were aiming for. And we were aiming for less. And we got blood pressure down more, and we reduced our life expectancy more than the rest of the world. Then the rest of the world switched over and caught up with the newer recommendations, and we've continued to actually lower the targets even more for blood pressure today. You know, I think we've done a good job with hypertension. Part of that was the large-scale education program. We have not had as large a scale education program to deal with obesity and diabetes, and that's why they keep rising. I think that's a serious issue. This actually is very recent data. It was published in the Wall Street Journal just a week or so ago. The other thing that we've seen is that there are people who now are centenarians. They live to over 100, and they've been called the welderly. And it turns out there's almost no difference between their biologic makeup, genetics, and that of their peers, but they are more physically active, more social, and typically better educated. We can certainly do something about the physical activity and trying to get people involved socially to try to improve our outcome and have a healthier lifespan, that health span being better. And strategies for doing this, the things that Eric Topol has advocated, and he's got a recent book on this, is take up strength changing, schedule your sleep and be sure to get enough of it, bolster your mental health, manage stress, and improve your mental health more broadly. Use tests and trackers sparingly. Don't go into all these things that are sold online, and be wary of these influencers because they're pushing some gimmick most of the time and not scientifically based. And he recommends for food choices that we focus more on fruits, vegetables, whole grains, unsaturated fats, nuts, and legumes. And these things will help us age more healthierly. Healthily? Yeah, I'll get that right somehow. And Camillo Riccordi, in his book on the HealthSpan Code, points out that the pillars of HealthSpan, and trying to do this, are predictive diagnosis years before the first disease symptoms will appear to identify invisible factors that you cannot defeat what you cannot see. Healthy nutrition, we mentioned that a moment ago, low glycemic index, anti-inflammatory foods, portion control, and considering intermittent fasting. Physical activity and exercise. He emphasizes that the chair is our worst enemy. We need to be up and around. Protective molecules to prevent or reverse silent inflammation and insulin resistance. Vitamin D3, omega-3 fatty acids, polyphenols and sirtuin activators, and GLP-1 receptor agonists. Brain exercise and mental health. We got to keep our brain working, have purpose, social life, listen to music, be involved. Integration with protective molecules that cannot be assumed by diet and that decrease with chronological aging when exercise is no longer enough. And consider the blue zone ecosystem. There's not a single bullet or magic remedy. We need to think about all these kinds of things. Yes, this sedentary chair being the culprit is illustrated by this picture of our change in activity level through evolution, that now we sit at the screen all day instead of being out hunter-gathering for various food and the like. So what do we need to measure this? Well, Zan in the beginning pointed out that Quest Diagnostics now has what they call the Cardiac IQ Insulin Resistance Panel and Score. It is a simple test. You just take it with a single blood sample. You know, you've heard from Ralph about, the gold standard with the euglycemic clamp, and you've heard from Jerry about looking at some of these things in depth, in detail. But what we need is something at the bedside that people can use to get an idea that insulin resistance is present. Because I agree with them that insulin resistance is the underlying factor that's responsible for much of this. And this just shows you that Quest has compared the IR score. It has greater discrimination than either insulin or C-peptide alone. It actually puts insulin and C-peptide levels together by GC mass spec measurement of it. And it does better on the right side than the HOMA IR, which some people have used as a quick way of trying to assess it, rather than using the clamp or the Matsuku index, which was mentioned that Ralph developed at one time, but that requires having multiple values, and you can't do it just with a single fasting sample. Some have suggested that the triglyceride HDL-C ratio may be an index of that, but the IR score does better than that, has a greater odds ratio of picking it up. And these were all compared to a large population that was studied by Jerry Reven at Stanford, and looked at the detailed measurements of insulin resistance that he used. And so what's the relevance of this, even in lean people? You're insulin sensitive if you have a score of 1, normal insulin sensitivity. You're totally insulin resistant at 100. By 33, or about a third of the way up, you're 4-fold more likely to have insulin resistance than a patient with normal insulin sensitivity. And at 66, you're 15-fold more likely to have insulin resistance. So it does help you pick out who may be insulin resistant, and you can target that. Zan asked in the beginning, he wanted to know a measure for HealthSpan that would be equivalent to A1C or LDL cholesterol. Insulin resistance score may be one way of getting to that on a large scale basis if you're not doing euglycemic, hyperglycemic clamps, which in the course of the clinical trials to get drugs approved for insulin sensitivity may be necessary, but in assessing things in clinical practice, this IR score that you can get from Quest right now may be the answer. And then we mentioned, and Jerry mentioned, and I mentioned in showing you the slide earlier, what things you can do. GLP-1 medications, they're common right now, and everybody talks about them as drugs. They were originally developed to treat diabetes, but they've also been now widely used for lowering weight. But it turns out they decrease cardiovascular risk factors. They decreased cardiovascular outcomes, including stroke, heart failure, myocardial infarction. They also decreased the metabolic liver disease that Jerry was talking about, decreased kidney disease, decreased sleep apnea. They have effects on many inflammatory markers and inflammation. And they're being studied now for neurological diseases, Alzheimer's and Parkinson's. They already have been shown to decrease stroke, so they offer neuroprotection. They may actually, and are being studied also for looking at substance use disorders, alcoholism and drug use, and compulsive behaviors. They also may benefit from GLP-1s. And we've already mentioned the myocardial infarction, atherosclerosis, metabolic liver disease, and diabetic kidney disease. And so we get a lot of these things from GLP-1s, and I think that we ought to be thinking about them as a real way to expand our health span so that it becomes closer to our lifespan. And I'm a big advocate of that. You could argue that some of this may be due to consequence of weight loss. Nothing wrong with that. But some of it is direct effects. And I think that's important to bear in mind. So in the center, you see the evidence-based things that it has been shown to decrease. Diabetes, obesity, cardiorenal disorders. And so established benefits for kidney disease, myocardial infarction, heart failure with preserved ejection fraction, and stroke. And it's being investigated further for metabolic liver disease, Parkinson's, peripheral artery disease, and Alzheimer's. So I would champion as the one thing that we might have at the current time that we could potentially be using for promoting health span, which is what Zan was asking about, is GLP-1 receptor agonists. And he put forward the combination of what he called rapamycin and metformin. They've worked well in animal models, but rapamycin has its own potential side effects that can be quite serious. And metformin, if you really want it to be effective, you have to take enough of it. Turns out that the average dose prescribed for metformin for type 2 diabetes, where it's useful, in the United States is somewhere between 1,000 and 1,100 milligrams a day. And if you really want to get the great effects from metformin, you need to be upwards and above 2 grams a day in the 2,000 to 2,400 milligram dose. And people don't do that. So if we're going to use metformin more, we need to be coupling it with the message that they need to be using adequate doses. So I think that what that says is we have 3 things around at the moment that we can think about that have been mentioned today. One is metformin. I'll leave the rapamycin portion out of your hypothetical there, Zan. But metformin, if we advocate for high doses, we need to advocate the same way we did for blood pressure in the 1970s. We need to have a campaign to get it right. Pioglitazone that Ralph mentioned, and GLP-1s. I think we have 3 things there that we can use already to promote healthy lifespan, and those would be the ones that I'd be pushing for.
Well, terrific, Jay. You've given us a lot of food for thought and some things to come back and maybe discuss a bit. But let's now make this a wider discussion. We'll take some questions that we've already received. And one of them is over to Jerry. Is metformin magic?
It's certainly an enigma. We've been prescribing it in some way or another for over 2 centuries, and we're still arguing how it works. I'll tell you what I think. clearly it lowers in poorly controlled diabetes. These are things I'm pretty sure about. It lowers fasting hyperglycemia, and that's through reductions in hepatic glucose production due to reductions in gluconeogenesis. And that's in patients. The question is, how does it do that? Most, I think, evidence there was an interest in AMPK activation. It does do that, but the reductions in hepatic gluconeogenesis are independent of that. In my view, it basically increases cytosolic redox state through inhibition of this glycerol phosphate shuttle, which is inhibited indirectly by inhibition of complex 4. I'm kind of in a minority there. I think I may be one of the only people, the only person on the planet who thinks this. I think the rest of the world thinks it's complex 1. Since we want to get into mechanisms, Zan, you encouraged me to get into mechanisms. The reason it's not complex 1 is you only inhibit complex 1 at millimolar concentrations. Our patients, even at 2 grams, 2.4 grams, you're at micromolar concentrations, and that does inhibit complex 4 at micromolar, but not complex 1. Secondly, when you knock down complex 1, you don't get, in mouse models, you don't get reductions in glucose, but you do when you knock down complex 4. And finally, when I told you everyone, I think multiple groups have shown this increase in cytosolic redox state with metformin. That happens with complex 4 inhibition, but not with complex 1. So having said that, it's really gluconeogenesis. One of the biggest misconceptions, I think, when I hear metformin discussed, is it or is it not an insulin sensitizer? And I'd like to just make it clear, at least in my thinking, is, again, most of it is through reduction in gluconeogenesis, but through reductions in glucose and glucose toxicity, you will have this improvement in peripheral and hepatic sensitivity. And these are studies I did with Ralph and Luciano Rossetti. Glucose toxicity is a real phenomenon. This is why our type 1s are insulin resistant. And again, as Ralph has really, I think, brilliantly shown, you get rid of glucose toxicity and you can reverse insulin resistance that way. So I think secondarily, metformin will have this sensitizing effect, but it's not a direct effect through glucose toxicity, and will only happen when you're hyperglycemic and get down to normal glycemic levels. And the last thing I'll say about this, last thing, I know Ralph is dying to say something. Last thing is, we've studied now, and we're writing it up now, and this is appropriate for now, the use of metformin in aging, and we'll talk about the TAME study maybe. But these are normal glycemic individuals. What effect does it have? Because you have normal rates of hepatic glucose production when you're normal glycemic. It still has a slight glucose lowering effect. And what does that do to? And the studies we've now just shown in normal glycemic individuals, doses of 2 grams a day, actually promote glucose clearance and increase glucose conversion to lactate. And that's perfectly consistent. Again, when you inhibit the mitochondria, whether it's complex 1 or 4, like I think or others think, either way, you knock out the mitochondrial electron transport chain, you decrease oxidation, you take glucose down to glycolysis, more comes out as lactate. So in this way, you're promoting increased glucose clearance, and that actually is responsible for a little bit of glycemic A1C lowering, independent of this reduction in normal in hepatic glucose production. So that's, I think, again, has relevance to use of metformin in the normal glycemic individual. Ralph, I know you're chomping at the bit to say something.
Well, indeed he is. And so, but the simple answer is metformin is somewhat magical.
Well, in that way, again, I would like to understand, again, I don't like the use of magic in science. It does things, and I think clearly it's in the mitochondria. I don't think there's little doubt there. And whether it's electron transport chain 1 or 4, that will work out. But I think if we understand this basic mechanism, we can actually maybe come up with an even better metformin. But I think that's why I think it's so important to understand mechanistically how these drugs are working.
Yes, indeed. Well, Ralph, over to you. Metformin is your baby, but you're also an advocate of a true insulin sensitizer. So take it
Yeah.
away.
Yeah, so as you'll know, the entire drug development, metformin, I supervised. And actually, when we did that, we actually did insulin clamps in people. And we never could show at any dose level that metformin improved insulin sensitivity. Moreover, metformin gets into muscle cells through the organic cation transporter, and that basically doesn't exist in muscle. So there is some small buildup of metformin, probably through passive entry. But there's no way, because people have done PET studies with labeled metformin, and metformin doesn't accumulate in the muscle. So it would virtually be impossible for it to be an insulin sensitizer. And in fact, we showed that. The thing you have to be careful, and by the way, everything Jerry said about gluconeogenesis is absolutely correct, and we've done very similar studies. But people have to be careful. About 20% of people cannot tolerate metformin. They have GI side effects. And I think some of the confusion that's come in the literature is that people lose weight on metformin. And when you lose weight, even 2-3 kilograms, that can improve insulin sensitivity. But I'm pretty convinced that metformin does not improve insulin sensitivity in muscle, and all of its effect is in the liver. So if we're talking about insulin resistances, at least in muscle, being the driving force, I'm not a strong advocate of that sort of line of reasoning.
Yeah, no, again, no disagreement. I should mention, I think one of the best studies that studied this was our colleague Jerry Olewski. And so he took type 2s and treated them with, I think at that time, troglitazone and metformin. And he showed that, both lower glucose, but when he brought in the diabetics and gave them insulin infusions, normalized their glycemic level, then troglitazone continued to have improvement on peripheral sensitivity, yet metformin had no effect. So again, I think we're all in agreement. Metformin is not a sensitizer, and it works on the liver and hepatic gluconeogenesis. Yeah.
But Ralph, you like pioglitazone, and it is a insulin sensitizer. What would you say about using pioglitazone as a health span approach?
As I said, I can't see the screen, but if it's possible, you have my slides. The very first slide after I ended is a pioglitazone slide, because I do think, as Jay pointed out, we have a number of choices: GLP-1 receptor agonist, pioglitazone, and then the mitochondrial target. I'll make a couple of comments about the mitochondrial target. I don't know if you can get slide 13 up. But these are,
Well,
if you can,
just speak to it conceptually.
let me
In the
speak to
shortness
it
of time we've
conceptually.
got.
Yeah. So what we showed was, and again, these are all human studies, that pioglitazone activates that insulin signaling pathway. It markedly increases glucose transport into the cell. It markedly increases nitric oxide generation. It is a true insulin sensitizing drug. And we know from the IRIS study, remember, those were people who had strokes with a mean hemoglobin A1C of 5.8. In the IRIS study, those people were treated with pioglitazone or placebo. Even the people with an A1C less than 5.8, there was a 30% reduction in recurrent cardiovascular events and a marked reduction in the conversion to type 2 diabetes. So we actually have a study, and to get into the IRIS study based on the HOMA-IR, you had to be insulin resistant. So we actually have a study in insulin resistant people who have an A1C that's less than 5.8, saying the pioglitazone works. And we've published the data in terms of the heart, the major misconceptions. If you look at pioglitazone, what it does in normal, in people who have diabetes without HFpEF or mild HFpEF, there's a 75% improvement in insulin sensitivity in the myocardium. There's a major increase in myocardial blood flow. There's a significant increase in ejection fraction. If you look at every measure of diastolic dysfunction, E over A, E over E prime, every single thing gets better. So people get confused with the peripheral edema. The edema is all because you vasodilate. the blood pressure goes down. And when you underperfuse the kidney, you hang on to salt and water. And if pioglitazone were named amlodipine, this drug would be approved for heart failure because people use amlodipine, cardiologists do, and the incidence of edema is about 20 or 25%. And pioglitazone and amlodipine are basically doing the same thing, but people get upset with pioglitazone, but not with amlodipine. So we're working with a company called Sirius to develop an insulin sensitizer that would do what pioglitazone does, maybe by working on the pyruvate transporter without activating PPAR gamma. And that may be a way of getting around the fat weight gain and the fluid retention by having an insulin sensitizer. And then Roger Shih and I are working on an ALCAP1 inhibitor that really works on the mitochondria. So I think that there are other approaches, and we clearly need new approaches to improve insulin sensitivity in addition to the 3 that are out there.
I would
Well,
argue,
thank you. Well, Jay, I just wanted to come back to, before I come over to you, to thank Ralph for the really great summary about pioglitazone. And by the way, we'll have Roger on at another session, along with Jerry Kolka, who's got to be glad that you mentioned his efforts with Sirius and yet another approach. But Jay, over to you.
yeah, I was going to
And
say the side effects of pioglitazone can be avoided in most people by keeping the dose down, trying to stay at 15 or at most 30 milligrams and avoiding the 45 milligram dose. You will minimize those side effects. If you stay at 15, you practically don't get them at all, but you might want to be up to 30 to get the full effects on insulin sensitivity.
What Jay
well,
says is correct. And when we analyzed with Silvio at Yale, we looked at the dose response curve in the iris. The cardiovascular protection in the iris study was equally apparent at 15 and 30 milligrams as it was with 45 milligrams. The other thing you can do is you can put the and this is all published, you can put the pioglitazone, we did this with liraglutide, and you actually get all of the weight loss that goes with liraglutide and no fluid retention. And we've also done the pioglitazone SGLT2 inhibitor combination, and that also attenuates the weight gain and the fluid retention. So maybe today the best 2 drugs that are out there are pioglitazone with one of the newer GLP-1s.
well, that's a
I'm for
great
that.
idea, Ralph. But let's stay with Jay a moment, and we're going to queue up Thomas to take some questions off the chat. But Jay, you are an advocate of GLP-1 agonist, perhaps for health span purposes. But let's also keep in mind that there is some adversity associated with GLP-1 agonists, and it may not make them suitable for people who are younger, who don't yet have disease, and for whom the benefit risk may not be positive. So just to make that distinction, that we've got abundant evidence that GLP-1 agonists help people who are overweight or have diabetes, but we don't have data yet for people who are pre-disease, at least not much data.
It's accumulating now, and my argument is that the issues with GLP-1 receptor agonists in terms of adverse effects are not serious adverse effects. Mostly, they're usually just
Muscle loss,
GI.
osteoporosis. We're
If
talking
you,
about decades of treatment now.
yeah,
Gotta have a safety profile.
I've been on GLP-1s for 2 decades myself, and you avoid the osteoporosis and and muscle issues by maintaining good physical activity. I'm in the gym 3 mornings a week to do that, and you can totally overcome those things. And there's not really, if you look at risk benefit compared to other drugs and serious things that are not preventable, there's very few of them. I mean, and I think that I would argue that they are, they are like the statins that you mentioned earlier, or something that we ought to be using for a wide scale basis to try to improve health span.
But just to point out, statins are not a health span agent or
No.
category. They,
No,
they,
I'm
as
not
you
clear
know,
about
they reduce cardiovascular disease, but they actually increase the risk of diabetes. So we have to take that into account.
that. That's arguable too, but we won't get into the details of that.
Okay. All right, fair enough. Thomas, throw some questions out.
Well, I want to exercise privilege here and ask the question I just put in the chat. Back to the general question, is insulin resistance as a number a candidate for a basic health metric like A1C or blood pressure or et cetera? How about as an aging metric? What more do we need to know to decide? And what are some other candidates?
Let me start to answer that. My very first NIH grant, 1975, was from the Gerontology Institute. And it was basically to look at insulin resistance as a function of age. I know 1975 people, that's like, in the archives. And if it's more than 5 or 10 years old, people have
Last
forgotten.
century.
Last century. But what we showed very clearly is a dramatic age-related decline, independent of changes in body weight, and insulin sensitivity. So I would say that they're pretty good data. And we also have data from the Gerontology Center, Ruben Andrus and Jordan Tobin, that as people get older, and these are non-diabetic individuals, that insulin resistance becomes more predominant. So I think there's a lot of data out there linking aging with insulin resistance. And now, can we overcome this? Well, there are drugs. Jay mentioned, exercise. And when Ricardo Bonadonna was a fellow, as part of these aging studies, what he showed is as the people got older, and Jerry Schulman mentioned this earlier, that what happens is that even though they have the same, quote, BMI, there's a marked increase in body fat and a decrease in muscle mass. So these are age-related changes for which we actually have things that already could potentially be used. Now, in terms of the GLP-1 receptor agonist, I think you have to be careful in aging people because there is a decrease in muscle mass of using these drugs. But in the average diabetic person, if you lose 30 kilos, you should be losing some muscle mass. And I think whether that you're losing muscle mass disproportionately to the decrease in body weight, I would say this is a very controversial topic at this point. But again, in the aging population, that would be the population that I would be most concerned about using the GLP-1. Although I think, as Jay said, if you have to pick one drug to treat diabetes, that's probably the drug I would choose along with Jay.
Jerry?
But I feel good as
Yeah, no disagreements. I mean, it works. I think again, as I'd like to know more mechanistically, I think a lot of it is through ectopic lipid. We don't, again, we certainly know it lowers liver fat, which is ectopic lipid, but its effects on the periphery. I think most of it is, again, even before major weight losses through the mechanism we described. Again, to me, the issues are really compliance. I mean, why is it? Now, Jay's maybe an exception being on it for 2 decades, but whatever, 1 or 2 decades. But most people, I think the data says half the people stop taking it for some reason or another after 1 year. And I think that's a concern. And then the pricing, hopefully that will change. But as we know, only a small percentage of individuals who could be on it, even again by definition, are on it. So again, these are other issues. And again, things are evolving. Hopefully, we'll get into oral small molecule GLP-1 analogs. Prices will come down. But again, is compliance an issue in terms of these side effects, which are there? Is that a reason people, or the fact that people's weight levels off? It's hard to get back to everyone's, what they were in high school, whatever. You lose weight, substantial amounts, but people say, "Oh, I've plateaued," and maybe that's the reason they stopped taking it. So I think that that's a wonderful drug. Not arguing it's transformed the lives of millions of people, but I think we need additional drugs. that again, if we understand molecular mechanism, we can make even better drugs, and certainly combinations. Again, I'm most excited about again, mitochondrial inefficiency combination where you have energy in reduced with a GLP-1 analog. You have increased energy inefficiency, and we've already shown in preclinical studies that gives additive weight loss. And the other thing is when you promote mitochondrial inefficiency, you do not lose lean body mass. So that's a nice thing, and it's really well tolerated. There are not any GI toxicities. So one could have a combination, get down to target weight, get rid of the insulin resistance, and then back off on the incretin and maintain on a protonophore or something like that to promote mitochondrial inefficiency. So, that's
On that point,
my thinking of the future.
on that point, Jerry, what about the thyroid receptor
Ah,
agonists?
yeah. So, the THR beta agonist, they, again, first FDA approved drug to treat MASLD and MASH because the first drug to show actually can reverse both the inflammation and more importantly, fibrosis that really leads to the demise of our patients with liver disease. But it's not 100%, it's about 30%. So again, not all of individuals do benefit from them, but I'm encouraged by the fact that it's a metabolic approach that will fix inflammation and fibrosis. And again, we've shown, at least in preclinical studies, again, it's consistent with you get rid of the fat, inflammation goes away, and the fibrosis goes away. So here, again, we have a metabolic approach, rev up mitochondrial fat oxidation, and we can make a difference in the patient with fatty liver disease and insulin resistance. I will say one thing, though, is, again, we're activating the thyroid receptor in the liver with this. Thyroid has many, it's a pleiotropic, it's a transcriptional regulation thyroid hormone. And so we're affecting many genes in the liver. And we've shown in multiple preclinical studies that you actually, besides revving up fat oxidation, you stimulate gluconeogenesis. And so again, for someone with metabolic disease, prone to metabolic syndrome, diabetes, I've shown you how gluconeogenesis is not a good thing. You don't want to have that revved up in your pre-diabetic or certainly your diabetic individual is already revved up. And I think this will negate the beneficial effect of lowering ectopic fat. So you have two things, which one's good, you're lowering liver fat and that whole pathway gets better, you get less inflammation, fibrosis. But at the same time, you're actually potentially, at least, and we've shown this in preclinical studies, revving up gluconeogenesis, which is the wrong direction. And I think this needs to be tested sooner or later in humans with these new agents. And that's where, again, other agents don't have that stimulation of gluconeogenesis.
Let's see if we can squeeze one, maybe two questions. Thomas, right quick.
I really ought to raise some questions from the audience, but I just wanted to come back to my first question. Is IR a metric that we should adopt? Yes or no? Like A1C or so Jay is saying yes.
Okay. Raise your hands.
I want to treat
Yes.
insulin resistance in everyone. Everyone. We should, just like hypercholesterolemia and just like hypertension, I would advocate. And then I think, Tom, to your question, I think you want us to be a little bit more commitment. Is this index a good surrogate for insulin resistance? And it's not bad. I mean, again, if you're resistant, we have a marker to treat it. Again, it's better than fasting insulin or C-peptide. It's a start.
So as a layperson, I hear about useful topics like insulin resistance and metabolic syndrome. And so what's the problem? What's the obstacle to a general adoption? I'm assuming that this information can help biohackers. It can help medical practitioners. Someday it may make regulatory decisions, but there has to be some sequence of getting it out into practice.
Well, I'll go first. I know Jay and Ralph will want to wait, but so we have a marker. And the issue is we need then new therapies to treat it. So exercise, diet and exercise, yes. And again, we all tell our patients, please get out there, be active, lose weight. There's no pill for that. Now, maybe having just said that, maybe Jay will swear, well, there's not a pill, but there's an injection. GLP-1 is getting us there. And certainly, well, PO is an insulin sensitizer. So we have drugs, again, so you could have a marker, and then the physician can say, okay, I want you to stay active, get out of the chair, and lose weight, and then potentially these other agents, and use this as a marker like we do cholesterol. To me, again, it's again in the young individuals. Again, the question is whether you'd want to treat like our 20-year-olds who I showed you already have muscle insulin resistance, 1 in 4. They're prone to hypertriglyceridemia and low HDL and fatty liver. And I don't think I'd want to treat them as much as, again, PO is a sensitizer or GLP-1 does this for the rest of their life on this. So this is where, again, we may have a marker, but we need better agents that are going to be really safe, inexpensive, well tolerated to actually go and with confidence, like we do with statins, say, all right, you're in your 20s or 30s, you have hypercholesterolemia, and we're going to keep you on the statin probably for the rest of your life. So I think this is kind of where, in my view, the issues are, again, especially making the decision in the young individual.
So
The second half.
I think the dilemma with this is that if the goal is to increase health span, we need long-term longitudinal studies that show that these things are making a difference. And the issue then becomes what kind of control group one has. Is it ethical to randomize people to a control group if you're trying to increase longevity and you have things that actually are touching on markers that we think are important? And would regulators accept the insulin resistance score from Quest, or would they insist that you do a clamp to really demonstrate that insulin resistance is gone? And I think those are real questions that we need to ponder there. On the other hand, you talk about somebody in their 20s, I would have no qualms in putting them on pioglitazone for the rest of their life at 15 milligrams. You can get 15 milligrams of pioglitazone, a month supply for $5. It's a generic out there easily, and so it's not expensive. If you leave it at 15 milligrams, you're not going to get the side effects that we were talking about earlier. And I don't see any problem with using that for a lifetime basis. I also think GLP-1s would be good for that, but before I put people on it in their 20s, if they don't have other disease things, I'd wait for, as Jerry was saying, some of the pills that could be used. I don't object to a weekly injection, but the cost of making a drug and getting it into an injectable form is huge, whereas the cost of making a pill is very, very inexpensive. And I think we could hopefully get to the pill stage at a very low cost that we could afford to give it to populations at large. That may be a few years away. They need to earn back the innovation effort put into making the pills, so the initial cost will be a bit higher, not as high as the injectable, but I think soon it could drop to the same kind of cost that pioglitazone has.
Jay, that's a great summary for us to end on, at least for our official period of time. The FCC requires.
Can I make a comment about the Quest study? Because I don't want people to leave thinking that Quest test is an end all. If you'll read the paper, Jerry Reaven's name is not on the paper. And they use the insulin suppression test to get the correlation. And remember, the insulin suppression test, that involves infusion of glucose, insulin, epinephrine, and propranolol. So I would say, even though I'm a big believer of insulin resistance and finding a marker, I'm not sure that Quest test is really
ready
it's
for
not
prime
for prime
time.
time. Okay, fair enough. Fair enough. Now we're going to end officially now. Thomas is going to bring us to a conclusion. The FCC requires that we read a statement at the end. He's going to do that, but some of our panelists may stick around for an informal discussion. I hope we can keep going. But Thomas, you bring us to an
And
end.
here's
And
the
with my
boilerplate.
great thanks.
Here's the boilerplate. All registrants will receive the link to the recording within a day or two, as well as announcements of future Targeting Healthy Longevity 2025 sessions. Session 3 will be a regulatory primer for longevity biotech companies applying for the XPRIZE HealthSpan and ARPA-H Prosper programs. We're going to target July for that. And we have future sessions planned on sarcopenia and frailty and other programs. With that, the formal portion of this event will close with thanks to the panelists and to you, the audience.